if anyone knows someone that, maybe couldn't make it or has neuropathy or any sort of nerve pain that you feel would be interested in this presentation, then call into our office. We'll send you a link. Or you can just look us up on YouTube. It's RX Rehab, and then you'll be able to find the video. It'll probably take us about maybe a week to get it up there, but we'll have it up there. So anyways, like I said, people are going to be trickling in still, so if you have an open seat next to you and someone's hanging out in the back of the room, then we'll probably have them come sit by you. But just to start off, I want to tell you a little bit about my clinic, and then we've got Casey from Boston Scientific here that is one of the ones sponsored the lunch. So you can thank him for the food. Thank you, Boston Scientific and Casey. Yeah, and so he's got some devices with Boston Scientific that actually can help out with neuropathy as well, which he'll be taking about 5 minutes or so to explain what that is. But this whole clinic is just really focused on neuropathy. Dr. Tolstrup, he works in Las Vegas. He's a good friend of mine. This is the third lunch and learn that we've done this year. And I am a bit biased, but this is probably the one I'm most excited about because neuropathy it can be a very tough thing to treat. Very tough. There are options out there. We have some options that we have used to treat neuropathy. Dry needling is one that we've found success with. We also have a new device called Shockwave. It's a Softwave is the brand. It's a really cool device that can help out with all sorts of issues, pain issues, back pain, joint pain, tendonitis, etc. We just got it in the clinic. In fact, we were doing test runs on Wednesday, trying it out. We were giving free treatments to our patients, and one of our patients who's had back pain chronically now for 8 years came in the next day after getting a treatment, and he was absolutely floored by how much it helped him reduce his pain. So we've handed out little sheets of paper here. If anyone is interested in physical therapy, if you have joint pain, low back pain, etc., if you want to try the Shockwave machine, we're super excited about it. We've got appointment times listed for next week on here. If you want to stay afterwards and set something up with the front desk, that's great. We'll be available to do that. If you're in a rush and you need to get out of here, you can just fill out your information on the piece of paper, circle the time that you want to, and then we'll call you and get back to you, okay? But we're here to help, whether it's, again, joint pain, low back pain, whatever you got, we've got some options for you. So that being said, I'm going to turn the time over to Casey. He's going to talk to you about some options that are available to you from Boston Scientific.
Thank you. I just clip this on.
Yeah, just clip it on.
All right, so if I can get this on. Can I put it on here?
Yeah, that's fine.
That way I can see what I'm doing. There we go. Hey, well, thanks everyone. I'm Casey with Boston Scientific. Thanks for giving me just a few minutes. Boston Scientific is a medical device company, and we work with a lot of pain practices here in the area. So oftentimes if you've gone to physical therapy, many times you don't need to go beyond physical therapy. They have so many great ways, so many different treatments that are helpful, but sometimes you might need something a little bit additional. They might refer you out to an interventional pain clinic, and those are the people that I work with. So the device we're going to talk about specifically today is spinal cord stimulation. Maybe some of you have heard of it, maybe some of you haven't. It's actually a procedure that we've been doing for decades and decades. So usually when I do these for a patient, they're like, is this brand new? What is this? Do I feel like a guinea pig? I'm like, nope, we've actually been doing it for many decades. I myself have been doing this for 14 years. So it's a technological therapy, which is really cool. And it it masks chronic nerve pain. So it could be radiating low back pain, radiating nerve pain down the legs, and neuropathy is a big one that we do it for. So it's not actually fixing, but it's actually masking these unhelpful chronic pain signals that are just driving people miserable. So this isn't the first thing that people try, even though it is minimally invasive compared to a lot of other procedures. Certainly you're going to try things like less invasive treatment options like physical therapy first. And even at an interventional pain clinic, they would try, whether it's epidurals, nerve ablation, things like that. And then they would determine whether you're a candidate for this or not. So some of the main benefits of spinal cord stimulation are that you get to do a test run first. So you get to test it out. In fact, this insurance requires it. You do a test period, we call it a trial. And most of the time, the trial is done just right in the clinic. So it's not, you can do it at a surgery center or hospital, but most do it just right there in the procedure room in their clinic. It's minimally invasive. And what they do is they place 2 leads into the epidural space of the spine. The leads they're about the size of a cooked spaghetti noodle. You can think of it that way. And they don't make any incisions for the temporary one. They do it through 2 needle pokes. So kind of similar if you've had an epidural done before, but instead of pushing medicine through, they're threading this little lead up through there. They remove the needles, and those leads then connect to an external battery, and they tape it down on your back, and you go home and you try this out for about a week and see if it helps. And now we want to make sure it doesn't just help. In fact, insurance says you need at least 50% relief. So we want to make sure it makes a significant reduction in your pain, and you notice an improvement in your quality of life. And the cool thing is, then you come back and you let the physician know, yes, I want it, or no, I don't. Basically, all insurances cover this, assuming you're a candidate, right? Again, they're going to have you try other treatment options first, such as physical therapy. So it wouldn't be the first thing you'd go to. But if you're at that point and you're a candidate, we really don't have issues with insurance covering this typically. Now, at that point, if you say, yes, this was a success, I want to move forward with the permanent one, the removal of the temporary one's done right in the clinic. It's not even a procedure. It's almost like pulling out an IV. Those leads slide right out. They send it to the information to insurance to let them know it was a success, and they schedule the permanent placement at a hospital or surgery center a few weeks later. So the permanent placement is not done in the office. The permanent one, a couple of incisions are made, small incisions, because this time they'll actually anchor the leads down to the tissue so that they don't migrate, and they place the little battery pack typically in the flank or in the upper buttock, and that's what powers this. And so once those incisions are healed, there's no restrictions as far as showering, swimming, even MRIs. You go and live your life with hopefully a lot less pain. So it's been a phenomenal procedure, phenomenal option for a lot of patients that have tried so many other things and said, I'm either not responding or I don't respond for a very long time. And this has been a great option for them, including for neuropathy. So these things are technological. They continue to advance. In the 14 years I've done it, they've advanced a lot. It's pretty amazing. And we're going to see that again in 5, 10, 15 years, right? So one of those areas where we do a lot more of them now versus when I first started is with peripheral neuropathy. So it used to be more so for low back and things like that, and we do a lot for that. So for patients that aren't doing as well to other treatment options, this has become a great option for them, for many of them. And like we say, you get to test it, try it out, and let us know if it's right for you. You have a little remote control to operate it, but really the role of me and my team is we try to make it as easy on you as possible. So there's 2 main ways you can run it. There's a lot of subcategories, but you can feel the stimulation all the time. Kind of feels like a TENS unit. Or most people run a sub-perception setting where you actually don't even feel it. It's running 24 hours a day, masking these pain signals being sent up to your brain, but you don't even feel it. And it's just a preference. Both ways work, but we set it up and we make it very automated and easy for you to use. Some people don't even touch the remote control. Some like to switch between different settings, but it's real easy to use. We set it up for you on that end. So other than that, anything else you think I should cover? I see a couple questions. Yes?
Where's your office?
So as a Boston Scientific, we actually just work with all the physicians that do this. So we don't have an office that you go to. It's more so if you go to your physician at a pain clinic and they determine you're a candidate, then they let us know, hey, we're going to do the procedure. So we work with many physicians. So I actually gave a handout which shows just a few. There's more. If you live here in Utah County, pretty much all the pain clinics around here we do these with, or even Salt Lake County, really anywhere. And so we don't have an office that you'd go to. It would be whether your doctor determined you're a candidate, and then they would let us know, hey, we're going to do this stimulator trial on such and such date. Yes. Yes, right behind. Great question. Numbness, typically no. Burning, pain, tingling, those sensations, absolutely. Numbness, it does not directly help numbness. Have I had patients say they got a benefit of numbness? Yes, but I wouldn't say it's directly from the stimulator. I think maybe in a macro view over time, because they're more active, they have less pain. I don't know, maybe blood flow increases, perhaps. But I always tell patients it's not going to directly help numbness. If down the road it happens to help you, consider yourself lucky, but I wouldn't go in with that expectation. Yeah. Yes?
So you actually do the surgery, not Dr. Stringham?
No, so Dr. Stringham in that example, or the pain provider, does the surgery. What I do is I manage the equipment, the stimulator. We program it, as we call it. We're the ones that control the current, turn it on, set it up for you. So we handle everything related to the stimulator, but we are there in the procedure with the physician, but the physician is who does the actual procedure. We just are in there to test it and make sure it all works well. So, yes.
Have you had any experience with someone using this and then having it taken out, and is the pain gone? Could it be gone forever? Does it get worse?
Good question. It's not going to cure anything. So it's not going to take away, like if you then have it. Now to back up, it is a reversible procedure. We call it a permanent placement, but it's not actually permanent. If for some reason, for some unforeseen medical reason, you needed it removed, surgically it can always be removed. We're not structurally changing anything to the spine. It's not like a fusion or something like that. It can always be taken out surgically, but if it's turned off or taken out, the pain is going to return. It's not going to cure anything. It's masking.
Is it a little bit different with the nerve block?
Yeah, this is an actual implant. So these leads are placed inside the body, sending this signal. So it is different from a nerve block. And then we can probably get to other questions later. I want to get out of the way of our real speaker today, because I promised I'd only take a few minutes. But if you have more questions, what I would say, because these are all great questions, is we have a form here for spinal cord stimulator interest. If you can fill that out, we'll collect these at the end. Or if you are already seeing an interventional pain specialist, you can go and ask them. And this also directs you to our website on the bottom of here, pain.com. Yes, I'm sure they paid a lot of money for that. Pain.com is our website, so you can go and learn all about spinal cord stimulation and even get connected with us further. So thank you so much for your time. I appreciate it. Now, turn it back over to you.
Okay. All right, give him a hand.
Oh,
Thanks for the lunch.
I don't want to walk off with this.
All right, without further ado, Dr. Tolstrup, I'll let him take over.
How's everybody doing today? Good to see such a great turnout. I'd just like to thank Scott, in my opinion, probably the finest physical therapist on planet Earth, and even a better human being, if that's possible. So when he offered me the chance to come and do one of these lunchtime educational things, I sort of jumped at the chance. My name is Tim Tolstrup. I'm a pain-focused peripheral nerve surgeon, and my practice is down in Las Vegas, Nevada. The title here is right there. It's Diagnosing Undiagnosable Pain. Peripheral nerve pathology, the missing piece of the pain puzzle. So what is the single most common reason that people seek medical care? Good call. According to both the NIH and the CDC, pain is the primary driver for people seeking medical consultations. It's more than heart disease, diabetes, cancer, all that combined. So when you think about pain, you sort of break it into two basic categories. You have acute pain, right? That's defined as pain that lasts less than 3 months. So you can think of that acute pain as an alarm system. The purpose, it's like a biological signal. It tells you that something's wrong, stop doing what you're doing, protect that area. And we typically expect this pain to resolve whenever the primary insult resolves. So if you broke a bone and it heals, you expect the pain to go away. If you had knee surgery and it's 2-3 weeks post-op and the surgical incisions are healed up, you expect that pain to go away. So that's acute pain, and we do a really good job in Western medicine treating acute pain. So the other half of that coin is chronic pain. This is pain that lasts longer than 3 months. That's just the definition. Less than 3 months is acute, longer than 3 months is chronic. So if acute pain is the alarm system, the thought is that chronic pain represents a malfunctioning alarm. It really serves no biological purpose that we've been able to identify. And the current defining paradigm is that this represents the nervous system sort of stuck in a high alert state. Essentially, the light switch is stuck in the on position. And they call that central sensitization. So the thought is like, whatever the insult was during the chronic or the acute pain phase, and that's all healed up, but the pain doesn't go away because now the process is up in the brain. There's something going on and the pain, and so you perceive the pain signal still, but the original problem is resolved. And we don't really have any expectation that this type of pain is going to just resolve spontaneously. The cost of chronic pain is immense, both in terms of dollars and the human cost. In 2026, they're estimating it's going to take about $700 billion to treat chronic pain. That's more than we spend on treating diabetes, heart disease, and cancer combined. Chronic pain is a factor in about a quarter of the suicides in the U.S. every year, and up to 30% of people who are treated for pain with opioids go on to abuse that, and which results in thousands of accidental overdoses every year. So what is chronic pain? Where does it come from? Anybody hazard a guess? Chronic pain is primarily peripheral nerve damage. At least if you give that answer, you're going to be right 8 or 9 times out of 10. Does anybody know what this is a picture of?
Can't see because you're right.
Does anybody recognize that? Anybody in the back, staff? You guys can chime in too if you want. Maybe. I don't know. I can't read it. No. Has anybody ever heard of the Rosetta Stone? Yeah. Okay, so this is a picture of the Rosetta Stone. This was discovered by one of Napoleon Bonaparte's soldiers as they were excavating a fort in 1799 in a town called Rosetta in Egypt. And the significance of this find is that the actual writing on there is like some kind of decree to the pharaoh at the time, Ptolemy V, I think his name was. But the significance is this decree is written 3 times in 3 different languages. Now, at this point in time, in 1799, nobody could read Egyptian hieroglyphics. Nobody knew what it was. It was sort of a dead writing system. And this discovery, it was written in ancient Greek, or it was written in Greek and in Demotic, which was the current written Egyptian system at that time, but it was also written in hieroglyphics. So this archaeological find was the key to unlocking the ability to decipher hieroglyphics. That's why we can read hieroglyphics today. So the Rosetta Stone has become sort of a metaphor for something that unlocks hidden knowledge or something of that sort. And just like the Rosetta Stone unlocked the ability to understand Egyptian hieroglyphics, really understanding peripheral nerve anatomy is the Rosetta Stone to unlocking the mystery of chronic pain. If you don't understand peripheral nerve anatomy, if you don't know what nerve goes to where, what nerve innervates this area of skin, what innervates that joint, then chronic pain is always going to be a mystery to you. Somewhere along my medical travels, I picked up this saying, the eye cannot see what the mind does not know. And when you're trying to diagnose things in medicine, this is critical. If it's not in your brain, you're never going to see it. Does anybody know what this picture is depicting here?
Like nerves. They look like peripheral nerves with telomeres at the end.
Yeah. So this is basically, if anybody's ever gone to the Body World exhibit down in Las Vegas, this is a dissection of the human nervous system. In the human nervous system, we generally divide it into two broad categories, the central nervous system and the peripheral nervous system. So everything inside the red line there is the central nervous system, basically made up of the brain and the spinal cord. Everything outside of that red line is the peripheral nervous system. Unfortunately, for almost all physicians, whether they've been out 30 years or they just got out of medical school a day ago, everything outside that red line is essentially a black box. They're very unfamiliar with it. They just don't understand the anatomy. So what I'm going to do here is I have a list of named nerves on the left side, and I'm going to have some audience participation. If you think you know, just shout the answer out. I want you to answer these three questions. I'm just going to pick a few of these nerves, not all of them. So number one, where can the nerve become compressed? 2, is there a named condition for that nerve compression? And 3, for bonus points, can you describe how that problem would present, or how would a patient with that problem, what symptoms would they have? So the first one here is the median nerve. We're going to go start easy and go to hard. Does anybody know where the median nerve becomes compressed? Anyone at all?
Your neck?
No?
Wrist.
And what's it called, Scott?
Carpal tunnel syndrome.
Has anybody ever heard of carpal tunnel syndrome? So that's compression of your median nerve right here. And generally somebody who develops carpal tunnel syndrome is going to develop numbness and tingling and pain, burning in these 3 fingers, maybe a little bit into that finger as well. It's very common in people who are using computers a lot. They're on the mouse all day. They develop this problem. All right, second one, common perineal nerve. Does anybody know where this nerve can be compressed? I'll give you a hint, foot drop. I saw some gesticulating over there. Actually, no. The common perineal nerve becomes compressed right here on the outside of the knee, right at the fibular neck. There's not really a named condition for it, but the way that this nerve compression presents is somebody might have aching down the front or outside of part of their lower leg, and numbness, pain, paresthesias on the top of their foot. In addition, if the nerve compression is severe enough, they may develop a foot drop, meaning they can't pick their foot up. If you've ever seen somebody walk with a foot drop, they kind of have to do this because they can't pick their foot up like you normally do, so they exaggerate the step and it kind of slaps down. All right, the lateral femoral cutaneous nerve. We're getting a little harder here. Does anybody know where this nerve can be? It's called the lateral femoral cutaneous nerve, not the femoral nerve. Does anybody know where this nerve can become compressed? Anyone? Do you know, Scott?
Yeah, upper thigh, on the outside of the upper thigh.
So the compression point for this nerve happens right at the inguinal ligament. If you feel your hip bone right here and just go just to the inside, this nerve comes out of the pelvis, has to transit under or sometimes through that inguinal ligament, and so it can become compressed here. Does anybody know what the named condition is? This is a... No, not really. No, she said not sciatica. That was a good guess, but it's not correct. Do you know what the name of this is? It's, hang on, who said that? Very close. It's neuralgia paresthetica. And do you know what that means in Latin? Well, in the words of the immortal Chaz Michael Michaels, nobody knows what it means. But it's provocative and it gets people going. It's a Blades of Glory reference there. I don't know if that was lost on this crowd. All right. The way that presents typically is somebody will develop painful burning in the thigh. It might just be numbness, or it could be numb and painful and burning, all down here like on the side of your thigh, where you would wipe your hands if your hands are wet and you're wiping them on your pants. That's where that nerve lives. Yes?
Is this exaggerated more like when you're laying on your back? Because I have those symptoms only
It-
when I lay on my back.
It could be. It depends. For some people, sitting is more of a trigger because as the more you sit, the more that tissue gets compressed. And for some people, lying down or standing up is worse because it puts that nerve on stretch. So it sort of depends on the specific pathology. The last one here, I don't think anybody's going to get this. It's the perforating cutaneous nerve. This is a nerve that comes out of the posterior pelvis. It can arise off the S2 nerve root or off the pudendal nerve. The pudendal nerve is a nerve that controls anal function and gives sensation to the genitalia. This nerve, what it does, is called the perforating cutaneous nerve because it actually travels through the sacrotuberous ligament, which is a tough ligament that goes from your sit bone to your sacrum bone. And this nerve travels right through it. So if this nerve becomes compressed, patients will typically have very painful sort of medial buttock pain. It's often confused for coccydynia or tailbone pain, or for a problem with the hamstring muscles where they insert onto the ischial tuberosity, the sit bone. What I'm going to do now is I'm going to go through a couple of like case examples just to kind of illustrate a couple of nerve problems and what these patients sort of go through many times. So this first one, this was a little 9-year-old guy who came to see me, but what had happened is a couple years before this, he had developed a viral illness in early May, which caused violent vomiting for about a day and a half. As soon as the illness passed, the vomiting went away, he started to complain of pain in the right lower quadrant, so this part of his abdominal wall there. The pain was constant, but it slowly started to get progressively more severe, and it never really changed location. There was no radiation of the pain anywhere. His pain was exacerbated by almost any type of physical activity, but in particular, it started to be triggered by eating. So this little guy started to have food avoidance and started to really lose weight, and to the point where they had to hospitalize him and put a feeding tube down to stabilize his weight. And while they were in there, they diagnosed him with celiac disease, but he did not respond to a gluten-free diet. And then, for some unknown reason, he started to get better during the month of August, to the point where he was able to get out of bed and get back to playing with his friends and doing everything else. Unfortunately, though, in September, he caught a cold, which with a lot of coughing that went with that. And after 3 days, all of his symptoms came roaring back. The horrible right lower quadrant pain, dizzy, nausea, food aversion, all that. His cold symptoms resolved, but the pain persisted. And so now his parents were getting progressively more sort of panicky about it. They took him back to the hospital. He underwent the $1 million workup. He had abdominal ultrasounds, upper endoscopy, lower endoscopy. They did CT scans, MRIs, ultrasound scans, everything they could think of, and everything came up normal. They tried him on antidepressant drugs. They tried him on antibiotics, antihistamines, steroids. Nothing touched this pain. Finally, out of desperation, his parents agreed to have him undergo a diagnostic laparoscopy and removal of his appendix, and his appendix came back on pathology as totally normal, and he still had the pain. So somehow his mom found me online. This is this little guy. This is a picture of him during one of his hospital stays, and then the picture on the right was when he came to Las Vegas. In the airport, he had to be wheeled through the airport in a wheelchair because he couldn't walk for more than about 15 or 20 feet due to this pain. Has anybody ever heard of anterior cutaneous nerve entrapment syndrome? Probably not. Most doctors have never heard of it, so don't worry. You're in good company. The anterior cutaneous nerve is actually the very terminal branch of an intercostal nerve that comes through your rectus muscle and through the anterior rectus fascia to innervate a little area of skin right over your six-pack muscles. We all used to have those, right? Those are the strap muscles that go up and down, those rectus muscles. So that little nerve that's circled in red, that's the anterior cutaneous nerve. The entrapment occurs right there in the second picture where the nerve is circled in red. The nerve has to come into the posterior rectus space, into the rectus muscle. It gives off motor innervation to the muscle, and then the terminal sensory portion comes through the anterior rectus sheath. Now there's usually a little vessel group that comes through there as well, tiny little artery and some veins. And so things like violent vomiting, violent coughing, blunt trauma to the abdomen, or excessive exercise sometimes can cause an injury to that little neurovascular bundle, and then the nerve gets scarred in right there, and the patient can start to have this horrible pain. So I want to draw your attention to the picture on the left first. This will get better as soon as I click on it, but this little red dot here, this is sort of a normal nerve, how it should transit through the fascia. You can see as that's pulled, the nerve glides. It comes out and then it goes back in, comes out and it goes back in. That's how the normal nerve is supposed to function. In this little guy, you can see how it's stuck to that fascia. There's no gliding of the nerve, and this becomes a very painful problem. In this picture, you can see this is the nerve with the black arrow pointing to it, and the other structures are little vessels. And then on the right side, you can see how tiny these nerves are. The nerve itself is actually usually sub-millimeter. The larger structure on the bottom is the little vessel that was accompanying it. So took this guy, what we did with this little kid is I examined him. He had this, usually these patients will have one spot that's very painful to push on. And we just block that nerve. Just like when you go to the dentist, you take some local anesthetic, you infiltrate it around that nerve, and his pain just went away like that. So based on that, we took him to the operating room. We found the little nerve, removed it, and this is this little guy today. He's back doing all the things he loves, hiking with his dad, eating birthday cake. He's totally pain-free. In the second case study here is sort of a conglomeration of 3 different patients. They all have the same problem, but sort of a different presentation. So the first one is a 33-year-old female. She had been in the habit of getting these facet joint radial frequency ablations, which is a common procedure done by pain management docs for spinal pain. And she had done fine with them, but she changed pain management doctors and had it done again, and the next morning she woke up with severe allodynia of the skin over the lower back and the buttock. What allodynia is it's pain out of proportion to what you would think the patient should have. So people with allodynia of the skin, sometimes even air moving across the skin can be excruciatingly painful, and that was the case with this young woman. Next patient, 46-year-old male, undergoes L5-S1 fusion for severe left radicular pain. So he had a herniated disc that was pushing on his L5 nerve root. He was having burning, horrible pain going all the way down his leg. He had developed a foot drop, which can happen also from compression of the spinal nerve root. This was recognized. He went in, he had spine surgery, and post-op, all that horrible pain went away. His foot drop recovered. However, now he noticed a new pain in the lower back area, just sort of lateral to the midline. Follow-up imaging showed a technically perfect lumbar fusion, and his spine surgeon was baffled. And this is a very common scenario, a very common story that I hear. The patient has spine surgery, there's still some problem. He goes back in, the spine surgeon's like, looks at his imaging, he's like, it's a perfect spine surgery, there's nothing wrong with you. Get out of here. So that was this person's situation. And the last one, 60-year-old female, she's a driver, she was rear-ended at a stoplight. She developed severe right-sided low back pain. The pain seemed localized to the area of the SI joint. Imaging did show some arthritis, some mild arthritis of the SI joint. So she ultimately underwent an SI joint fusion, and after surgery, her pain was no different. Then after that, she had a spinal cord stimulator implanted, and this also gave her no relief. So these 3 people, they sound real different up front, but they're all suffering from the same problem. Has anybody heard of failed spine surgery syndrome? A couple of years ago, in 2022, they rebranded to persistent spinal pain syndrome. I think failed spine surgery, they didn't like the connotation, so they rebranded to persistent spinal pain syndrome. So papers written since 2022 approximately go under this moniker instead of the old one. But it doesn't really matter what they call it. They've been writing about this problem since the 1970s. If you search in PubMed, which is a big medical database, you get back at least 20,000 unique titles for papers that have been written on this. It's defined as pain lasting 3 months or longer after the spine surgery, so you're in the chronic pain territory. Somewhere between 10 and 40%, depending on the study you look at, of all spine surgery results in some form of this syndrome. Approximately 1.2 million people undergo spine surgery each year in the U.S., so if you do the math on that, that means somewhere between 120,000 and 300,000 people every year end up with this persistent spinal pain syndrome. So that's 300,000 last year, 300,000 this year, 300,000 next year. You can see how the numbers of those patients really start to climb. The cost of treating somebody with persistent spinal pain syndrome, if somebody's diagnosed with this problem in their 40s or 50s and lives to a normal lifespan, so another 20 or 30 years, the medical care alone is roughly $1 million per person. If you add in other indirect costs like lost wages, disability payments, etc., that can easily double. Now, who's ever heard of the superior cluneal nerves? You've heard of superior cluneal nerves?
Yeah, from you I learned about this all.
Oh, okay, all right.
But I'm
Can you tell me where they're located, where you can find them?
The superior comes down off your, like,
Yeah,
there.
yeah, exactly, right in that general area. So here's a picture. You can see the red box and the little sort of white arrow. That's pointing to the superior cluneal nerves. It's a little bundle of nerves. There's one on each side, just lateral to the spinal column. In somebody who's had spine surgery and their back pain didn't go away, who's had back surgery and they develop new pain in this area, or somebody who develops this kind of pain has an MRI of their low back and the MRI looks normal, this is by far the single most unrecognized cause of that type of pain. These nerves are derived from the posterior cutaneous branches of L1 through L5. Most anatomy books just say L1 through L3, but in reality L4 and L5 are often involved. And the funny thing about this is it's an easy diagnosis to make. If you ask these patients where their pain is, they will point directly to the superior cluneal nerves. And as far as diagnosis goes, it's not that hard either. You lay them down on a table like this and you push right on the superior cluneal nerves. If that's the source of their back pain, those patients will come right off the table. What's happening here is these nerves are coming out of the strap muscles that run alongside each side of the spine. This is the iliocostalis lumborum muscle. The nerve is traveling through there. It's giving off motor branches to those muscles, and then when it exits the muscle, it becomes purely sensory. But there's a tough fascial covering over those muscles that the nerve still has to pierce through, and especially down on the iliac crest there, it becomes this tight osteofibrous tunnel. And this is where these nerves can become compressed, or they can be injured from other spine procedures. So to diagnose this, basically, when you have the patient lying prone on the table, all you do is start pushing along their posterior iliac crest, sort of firmly, start right at the SI joint and just press laterally about 3 to 4 centimeters. And if that's the problem, they'll let you know it. And then once you suspect this, you follow it up with a diagnostic block. So this is kind of like the same type of thing you get when you go have work at the dentist. They put in numbing medicine that should last 2 or 3 hours. This gives the patient a very good chance to sort of assess what the results of the block are. And if their low back pain is due to these nerves and you block them correctly, their pain it's like shutting that light off. So then what you do is you take these patients to the operating room and you just have to identify all the nerves. One thing about peripheral nerve anatomy is it's highly variable. So one person's superior cluneal nerves can look very different. One person might have 8, another person might have 4. You just have to make sure you get them all so that the patient has a good outcome. And you disconnect these nerves, you remove a fairly lengthy segment, and then you take the proximal end and you bury it down in those strap muscles. And that will resolve the problem permanently. All right, superior cluneal nerves we talked about. Next is middle cluneal nerves. By the way, does anybody know what cluneal is? It's Latin for buttock or haunch. So if you think superior cluneal nerves on the top, middle cluneal nerves are coming from the middle. These are the middle cluneal nerves here. Again, this is probably the second largest unrecognized source of low back pain or sacral pain in the situation where somebody's had surgery and the pain didn't go away or the MRI doesn't show a problem. These nerves are very commonly involved. These nerves come from the posterior cutaneous branches of the sacral nerve, so S1 through S5. Some interesting things about these nerves is S1 through S3 are what provide the dominant sensory innervation to the SI joint. So somebody where these nerves might be injured could experience pain that they would feel like is in the SI joint, but they might get an SI joint fusion and not have any relief of their pain because this nerve is injured further upstream. The lower nerves S4, S5, and the coccygeal are closely associated with things like coccydynia or tailbone pain. So somebody who falls onto their tailbone, breaks it, and has horrible sitting pain, tailbone pain, rather than remove the tailbone itself, which is a very important structural component of the pelvic musculature, you can go in and disconnect these little nerves and interrupt the pain signal to the brain. And this is just another picture showing these nerves coming out of those holes in the back of the sacrum and out of the sacral hiatus in the bottom, and they immediately start to form a lattice work or a web of nerves. So when you have to deal with these nerves, in order to get a good result, you usually take out all of them.
Is that a back view?
This is the back. So this is your pelvis. It's not really it's the sacral spine, but it's this pelvis area which makes the ring, and it's the sacrum which is the center.
Of the front?
Not in this presentation, but the front looks very similar. There's holes that come out the front and holes that come out the back. The nerves that come out the front are much more important nerves. Those are the nerves that create like your sciatic nerve and other important nerves. These nerves are relatively unimportant. The only thing they do is give some sensation to the skin over the sacrum and laterally out into the buttock. But if they're injured or compressed, they can cause horrific pain. The next little video I'm going to show you is illustrating this area within the green box, just to orient to what you're looking at.
Where's the sciatic bundle in this, or is that only viewed from the front? I was just curious.
No, so the nerves come out of the front, but then they come through the greater sciatic notch, which is this space here, to get into the deep gluteal space and then run down the back of the leg. So this is a little video intraoperatively showing these nerves, these sacral nerves. You're looking at the bone there. These little yellow elastics are called vessel loops, and so they're around each of the nerves. So that was S1, this is S2. As you come down, here's the S3 bundle, and then the S4 bundle. Those are the nerves coming out of the holes, and then the big hole at the bottom you have coming out here is the left coccygeal, and then the right coccygeal, and then the right sacral nerve root. This person's pain, very often people that have problems with these nerves, the pain is all one-sided, so you don't have to take out all the nerves on the other side. And this is a patient who did require all the nerves taken out, and that's just a picture of all the nerves after they're removed. All right, now we're getting into sciatic nerve territory.
Okay, I don't have sciatic. It doesn't go anywhere. It's like a man's groin pull by the femoral artery or femoral nerve. That's its sole location.
Okay,
And
so that probably doesn't involve your sciatic nerve, but there's other nerves that go to that area. We can talk maybe after the presentation if you want to talk to me. We can discuss that. Does anybody know what piriformis syndrome is? Yes.
It is the issues with the piriformis muscle that surrounds, that covers that nerve that can pinch it.
So there's a lot of Latin in anatomy. Piriformis is Latin for pear-shaped, and if you look at that muscle, you can sort of understand why they named it piriformis muscle. But piriformis syndrome is basically entrapment or pinching of the sciatic nerve between the bony pelvis and the piriformis muscle. So they're like the two pieces of bread, and the sciatic nerve is the jam in the middle, and it gets squished. This is by far the most likely reason somebody would be experiencing sciatica pain with either a clean lumbar spine MRI or following some kind of lumbar spine surgery that didn't correct the sciatica pain, or they might have lumbar spine surgery for isolated low back pain, and 2 or 3 weeks after that surgery they start having sciatica pain, but the lumbar spine MRI is normal. The treatment for this is to completely remove the piriformis muscle. Now it turns out that the piriformis muscle is kind of a spare part like your appendix. It has a job, but if you take it out, you would never know it's gone. And you can do that through a relatively small 2.5-inch incision right where this shows on the buttock there. Now, one interesting thing about piriformis syndrome is there's quite a lot of variability in terms of the anatomy of the piriformis muscle and its relationship to the sciatic nerve. So A and B are by far the most common types of occurrences. A is what most people have, just a single piriformis muscle, and the nerve is pinched between the bone and the muscle. But quite a few people have the configuration in B, where you essentially have two piriformis muscles, and when that occurs, the sciatic nerve is split into its two divisions, the medial division and the lateral division. And the lateral division, which eventually becomes the conperineal nerve, that nerve in foot drop, goes between the two muscles. So this is a picture of surgery. This is a view down into the deep gluteal space. In picture number 1 there, you can sort of see that bright shiny thing that looks like it's going side to side in the left side of the picture. That's the sciatic nerve. The piriformis muscle is the beefy red thing, and there's also something that looks like nerve coming across it, and that's the upper division of the inferior gluteal nerve. In picture 2, I've dissected it out a little better so you can see the muscle is more delineated, and you can see that there's also a very thick vascular leash, meaning some vessels in tough tissue that was kind of stuck to the piriformis muscle, and that's separated apart. In photo 3, the piriformis muscle has been completely removed. But what you can see there is the remaining vascular leash, and you can see how still that's very tight onto the nerve. So that gets removed and divided as well. And then in the last one, the operation's basically over, But you can see how the mass effect and the pressure on the sciatic nerve from the piriformis muscle and that vascular leash has kind of distorted the linear pathway of the muscle. You can see how that's curved. Now that'll bounce back no problem, but it's visual evidence of the compression of the sciatic nerve. This is another one. This is where that one where you have two piriformis muscles instead of one. So the picture on the left shows both piriformis muscle bellies with the lateral division of the sciatic nerve running between them. The middle picture is where we've removed the more superficial piriformis muscle belly. And then in the third picture, I was going through and thinking, okay, we just have the deeper piriformis muscle to remove. But in reality, this muscle had also split, and there was more nerve passing between those two muscle bellies. Now what this is sort of what I've done is this is the same patient. I reconstructed the positioning of those muscle bellies. Patients usually like to get little videos of the surgery, so I often do that. And this is for the patient's benefit, just to illustrate what we did. It's a little bit hard when you're having your iPhone and you're trying to get those things out, so I'm not usually that ham-handed. But that was the first piriformis muscle belly that's been removed, and then you can see how that deeper piriformis muscle appeared to be in relation to the nerve structures. But as I started to divide the muscle belly very medially and peel that back, we got a little surprise, and this is what we saw. So there was another nerve coming through that muscle, and it's very important that you don't injure these nerves. That nerve, which is fairly large, based on the direction it's running and its location, is probably a significant component of the pudendal nerve. So if you happen to injure that nerve, you could have somebody who might wake up with a numb penis, or their anal sphincter wouldn't work and they'd be incontinent of stool. So it's really critical that you are careful down here. This is an example. So when people do piriformis surgery, a lot of orthopedic surgeons will just release the muscle. In other words, they divide the tendon where it attaches to the greater trochanter. They're familiar with that because they see that muscle. They do that a lot for hip replacement surgeries. The problem is that the piriformis muscle is here, the sciatic nerve is here, and the femur is here. When you release that muscle, what you're doing is you're leaving a completely intact muscle in the deep gluteal space. The nerve supply and the blood supply come into the muscle very medially, so you haven't killed the muscle. What happens is the muscle droops down and ends up scarring down to the joint capsule or to the superior gemellus, which is the next short rotator of the hip down the line. And then you get this kind of a problem. So what I'm doing here is just stimulating this muscle. It's all scarred down. You can see what that does to the nerve when I stimulate it. See how that just crushes the nerve? It pinches and pulls the nerve every time the muscle contracts. So anytime this person was walking around and the brain would normally want to send a signal to the piriformis muscle, that was happening, but the nerve was getting crushed. And here you can see, after the muscle has been completely removed, you can see how erythematous and inflamed that nerve was, where the tough tendon of the piriformis muscle was rubbing against it and pinching it. All right, this brings us to diabetic peripheral neuropathy. Now, most of these concepts can be will work for idiopathic neuropathy as well, but we'll just talk about diabetic neuropathy right now. So who knows what diabetic neuropathy is? Do we have any diabetics in the group? Do any of you have diabetic neuropathy? Okay.
I don't know what it is, but yeah.
Well, neuropathy is just a fancy Latin word meaning nerve problem or nerves not working right. Sounds better when you say it in Latin, though. So these facts are from the American Diabetes Association fact sheet, which they gathered from the CDC. I had to update this slide for this presentation, and the prior data I had was from 2007. So in 2007, there was about 20 million Americans being diagnosed or that have diabetes, whether they know they've been diagnosed or they're undiagnosed. So in roughly 20 years, the number of Americans with diagnosed or undiagnosed diabetes has doubled, which kind of shocked me. So there's 40 million Americans that have diabetes and another 115 million Americans that have pre-diabetes or glucose metabolism problems. About 50% of diabetics will develop some form of peripheral neuropathy. Now, most of that is going to affect hands and feet, although sometimes there can be neuropathy that affects the digestion, the motility of the gut. There's other more rare types of neuropathy. About 18 to 49% of pre-diabetics will develop some form of peripheral neuropathy. And so if you do the math on that, there's 40 to 76 million Americans suffering from some form of diabetic peripheral neuropathy. So what is going on? Well, at the pathophysiologic level, you sort of have three main things that are affecting these nerves, and what it does is it predisposes the nerve to developing a secondary mechanical compression neuropathy. In other words, it predisposes the nerves to becoming pinched, any place that they pass through a tight space. So one of those is endometrial edema. The elevated blood sugar is pulled into the nerve. This causes the nerve to swell. The second thing is decreased axoplasmic flow, which prevents the nerve from being able to repair itself when it does get damaged from mechanical compression. So it's not able to respond as well as a normal nerve. And then you have glycosylation end products, which build up in the nerve and cause the nerve to become more stiff. So instead of being a nice, rubbery, pliable structure, it becomes more stiff. And all these factors together really make the nerve susceptible to chronic nerve compression. Just to illustrate this, on the left you have a non-diabetic nerve. You can see the whiteness of the nerve and the fascicular pattern. You can see those striations in the nerve. On the right is a diabetic nerve. And you can see how different those two nerves look. The nerve on the right is 2 to 3 times larger than the nerve on the left, and it's encased and infiltrated with fatty tissue. So a normal nerve, with nerve compression, basically what happens is nerves are like the electrical wires. If you stripped off the drywall, you'd see nerves running between the wooden studs, right? In between the studs, it's wide open, lots of room for that electrical wire to go. But where it has to pass through the stud, everything has to come down to a hole, an inch and a half wide. So when a nerve is normal, it fits well in that tight space. It might be snug, but everything fits. When you get the diabetic nerve, now you're dealing with this situation. That nerve is swollen and it no longer fits in that tight space that it used to. And that compression, that external compression on the nerve can cause all these symptoms like numbness, tingling, burning, all those symptoms. Now, one argument against operating on people with peripheral neuropathy or diabetic peripheral neuropathy is that the numbness, the symptoms, they don't really correspond to a single anatomic nerve distribution. So this can't be a surgical thing like carpal tunnel syndrome where the numbness and burning happens just in the median nerve distribution, these 3 fingers. In the diabetic or in somebody with idiopathic neuropathy, their whole foot may be burning and numb. Well, if you add together compression of the common perineal nerve at the fibular neck, compression of the superficial perineal nerve of the distal lateral leg, the deep perineal nerve at the dorsum of the foot, the proximal tibial nerve at the soleus sling, and the posterior tibial nerve in the tarsal tunnel, if all those nerves are becoming compressed at the same time because there's this metabolic process happening with the nerves, the patient is going to experience total numbness of the foot. Their whole foot can feel numb and can burn. And it's because they have multiple nerve compressions, not just a single nerve compression. Now, I can guarantee that if we went up the street to that August institution, the University of Utah Medical School, they're still teaching medical students today that diabetic peripheral neuropathy is an incurable progressive disease. But the reality is that if somebody has the appropriate physical exam characteristics, meaning when you examine them, do they show signs of nerve compression? For that subgroup of patients, nerve decompression surgery is about 80% successful in permanently relieving these symptoms. Now, so it doesn't work on everybody. We don't know why it doesn't work on 100% of people. Even those within that surgical pool, 80% of people will have good results and 20% will be no different. It doesn't make people worse, the ones that fail the surgery, but it just doesn't make them better. And it doesn't cure the underlying problem with the nerve. So the nerve's still swollen, it's still stiff, etc. But for most people with neuropathy, it's that external compression that's actually causing the clinical symptoms, not the underlying problem with the nerve. So the benefits of nerve decompression surgery in somebody who's got diabetic neuropathy is they have good pain relief. They can recover meaningful sensation, and that's important for balance. Anybody who's got significant neuropathy knows that after a certain point of sensory loss in the foot, your balance starts to go out the window. And maybe most importantly, in patients that have had those nerves decompressed, it virtually limits the risk of new ulcerations or amputations. Unfortunately, for most doctors who treat patients who have diabetic neuropathy, the idea that you can operate and cure the symptoms of diabetic neuropathy or idiopathic neuropathy remains kind of a heretical idea. So they'd like to burn me at the stake for saying that. All right. Do you want? How much longer do you want to go, Scott?
Good.
Okay. All right. Is everybody okay? They don't have to rush off anywhere? Okay.
We just got a patient at 1:30. So
Okay.
we're good.
I should be able to get to I think there's just a couple here. All right. So this is another interesting nerve. This is the posterior femoral cutaneous nerve. Do you know where that one is? Yeah.
I don't know, but it sounds like it's in the realm.
Yeah. So it's somewhere in the femoral region, right? You have a lateral femoral cutaneous nerve, that's the neuralgia parasitica. You have anterior femoral cutaneous nerve, which does the inside portion. That's not to be confused with the femoral nerve. The femoral nerve is the nerve that actually innervates your quad muscles. These nerves are purely sensory to the skin. And then you have a posterior femoral cutaneous nerve. So that's this nerve that I'm going to talk about. The posterior femoral cutaneous nerve basically innervates the blue shaded area. It gives sensation to a wide area, including the lower third of the buttock. It co-innervates the perineal area along with branches that come from the pudendal nerve. It also gives innervation to the upper medial thigh and then all the way down the back of the thigh, even extending down into the upper posterior calf. The interesting thing about this nerve is when this nerve is not happy and it's a pain source, it often can be misdiagnosed as like a spinal radiculopathy or sciatica pain. And very often patients with a problem with this nerve will end up with some kind of operation on their hamstring muscles, especially if an MRI of their hamstring shows some kind of tendinopathy or a little tear. They'll end up with the hamstring surgery. And when you do hamstring surgery around this nerve that's already unhappy, the patient is probably going to be worse. It's also a very common cause of intractable sitting pain. So people that have a lot of pain where the buttock meets the thigh or around that sit bone, that pain is really chronic. This is a very common nerve that's involved. I call it a plexus rather than just a single nerve because this is what it looks like in reality. It's not just a single nerve, and from one person to another, there can be a high degree of variability in this anatomy. So these are all posterior femoral cutaneous nerves from different patients, and you can see how different that looks. There's typically, though, 5 main divisions, and so when you go in to operate on somebody who's got an injury to these nerves, you just make sure you have to account for all 5 divisions so they have a good pain relief. All right, this is the last nerve condition I'm going to talk about. Is anybody familiar with thoracic outlet syndrome? Yeah. Does anybody know what it is involved with thoracic outlet? What's the problem? I have it. Oh, lucky you. All right, so there's 3 types. There's an arterial type, a venous type, and then a neurogenic type. The arterial and venous type, they're pretty easy to diagnose, and combined they only make up about 5% of everybody with thoracic outlet syndrome. The other 95% are neurogenic thoracic outlet syndrome, meaning it's involving compression of the nerves. The primary point of compression in this condition is between the anterior and middle scalene muscles. These are small muscles deep in the side of the neck. All the nerves in the brachial plexus come between those muscles. That's the primary compression point. There's also a secondary, much less frequent compression point right at the pec minor tendon here. So this is another place where the brachial plexus can be compressed. True mechanical compression of the brachial plexus between the first rib and the collarbone, the clavicle, is exceedingly rare. And what that means is there's no need to remove the first rib, generally speaking. Many people who do this surgery still remove the first rib sort of as a matter of course. One of the most difficult things about treating neurogenic thoracic outlet syndrome is getting diagnosed correctly in the first place. The brachial plexus is very complex. There's a lot of nerves coming off it that are going here, there, and everywhere. And so you can have 2 people that have neurogenic thoracic outlet syndrome, and their presenting picture may look quite different. And very often what happens is their pain may be sort of magnified in a specific area, and then what happens is the doctors get blinders and they sort of concentrate on that one area. The patients end up getting neck surgery or shoulder surgery or something like this when all along the problem is this neurogenic thoracic outlet syndrome. Most surgeons who do this type of surgery, I would say, are vascular surgeons by training. So they're not peripheral nerve surgeons. For that reason, they're sort of one-trick ponies. You know, if you have numbness and pain and the spine surgeon says it's not the neck, then they'll say, okay, come here and we'll take your first rib out. That operation works to the extent it does because when you take the rib out, it disinserts the anterior and middle scalene, so you do relieve some of the pressure on the nerves. But a real thorough brachial plexus decompression involves complete removal of the anterior and middle scalene muscles. Kind of like the right surgery for piriformis syndrome is complete removal of the piriformis muscle. You don't want to leave those muscles in there that can scar back down to the plexus and then retract and cause additional pain. So this is just the picture on the left is sort of a schematic of the brachial plexus, kind of gives you an idea of sort of how complex this structure is. And on the right, it gives you an idea of where this is located. So the brachial plexus sort of starts where the nerves come out of the bony spine and ends about at the armpit level. So this is the plexus in here. This is a picture, some intraoperative pictures. The picture on the left, the forceps are pointing to the anterior scalene muscle, and then you can see the other muscle more to the right in that picture. That's the middle scalene muscle. This white nerve coming across the anterior scalene muscle is the phrenic nerve. That's the nerve that makes your diaphragm work. So it helps in breathing. It's very important in breathing. And the other ones are the supraclavicular nerves, which gives sensation to the shoulder and the skin over the upper chest. In the picture on the right, that's when the operation's all done and the anterior and middle scalene have been completely removed. So you can sort of see the anterior scalene would be where the yellow shading is, and the middle scalene is where the green shading. So you can kind of see what those nerves look like, or what those muscles look like when they're present and when they're removed. And here's just the same patient, same operation, but you sort of have two views. You have one view going up towards the neck and one view going down to the shoulder. And so this just shows you all the complex structures. When you're looking up towards the neck, you can see the C5, C6, C7, C8, and T1 nerve roots. And right in the bottom left of that corner, you can see you're peeking at the top of the lung. And the only thing separating you from the top of the lung is a cellophane-thin layer of what's called parietal pleura. So it's the tissue that separates the lung and keeps the vacuum around the lung. If you violate that, the lung can collapse. Looking downstream, you can see the other end, and you can see structures like the cephalic vein and the subclavian artery. The point is that there's a lot of very important structures packed into a tight space, so it's sort of tricky to work there.
Did this patient end up noticing an improvement in their diaphragmatic breathing and not so much as using their upper?
Well, most patients who have this problem don't really notice a problem with the diaphragm. Like, the breathing is usually not a feature of thoracic outlet syndrome because, to begin with, that nerve, if I back up there, that nerve is not really so susceptible to compression because it runs on top of the muscle there. But one of the bad complications of this surgery is you can injure that nerve, and then it paralyzes the diaphragm, which can really cause somebody to sort of have labored breathing. All right, so last couple of slides here. When you think about undiagnosable pain, if you're a clinician or just somebody who has chronic pain following any type of surgical procedure, chronic pain following any type of traumatic injury, or chronic pain which develops spontaneously for no apparent reason. And when I talk about chronic pain, I'm talking about this is pain that doesn't go away by itself. It's pain that you've come to Scott, he's worked with you, you just don't respond to physical therapy, et cetera, et cetera. Once you've tried all these less invasive things, you should consider it a peripheral nerve problem until proven otherwise, and you're going to be right most of the time. And I'll leave you with that. Thank you.
So we'll have some questions. We got a patient that's going to be here about 1:30. So, but until then, Tim, are you okay just to field some questions?
Yeah, absolutely.
Okay.
Does anybody have any questions? Thoracic outlet syndrome guy.
So, it's not to do with my TOS.
Can I ask you a question? How were you diagnosed, and what was the reason you developed it, if you know?
I had a lot of pain in my right arm.
Mm-hmm.
It would go down to my wrist. I worked as a dental assistant, and I couldn't even pull the propionate.
Mm-hmm.
And I went to a pain management clinic up in Salt Lake, and they did MRIs and everything, and they called me back and said that I had TOS.
Okay.
I didn't get. It was the most intense pain I've ever had.
Nerve pain is a different beast than regular pain. You know, pain from an injury, pain from a surgery, it's not like nerve pain.
And they said, just do exercises to stretch it out.
Well, I agree with that. If you have like something like piriformis syndrome or thoracic outlet syndrome, the first place you should go is to Scott, because sometimes those kind of conditions, like there's a whole spectrum of severity of any type of nerve compression, and I would say the mild to moderate types very often will respond favorably to physical therapy or a steroid injection or something like that. Surgery should really be the last resort and reserved kind of for those people who have failed those more conservative therapies and who are really impacted by the pain.
Do you condone blocks?
Yeah, I use blocks all the time, so I'm a super
I'm about
condoner.
ready for a permanent block. I've done
Well,
everything in the book, and I'm just shifting.
There's a lot of different blocks out there. The blocks that I use are purely for diagnostic purposes, but pain management doctors use a lot of blocks, and they're trying to produce a therapeutic effect, so they often will add steroid in with a block. And so they'll do blocks. You know, if you have facet joint pain, that can cause a lot of cervical pain, for example. If they block those facet joints and your pain goes away, then you're a very good candidate for a radiofrequency ablation procedure, which for that type of problem is by far the best thing you can do. Was it Jamie that was in here, Boston? Casey, our Boston Scientific guy who was nice enough to provide lunch. You know, that's another option for therapy, and you know, it works for some people. If it doesn't work for whatever reason, then the peripheral nerve surgery may be a good option.
I'm tired of all the terminology and its variants.
Sorry.
And none of them are ever concise. And they never, I mean, like, I used to be completely vital, healthy, all the numbers are outstanding, 0 plaque, calcium and whatever from the Women's Center. But you talk to a man and you say, hey, talk to me. Have you ever had a groin pull? Because it's constantly conveyed to me. My brain goes, groin pull, mostly for a man. That's not necessarily the case. But, you know, when I'm not a marathoner, triathloner, none of that. But swimming 2.5 hours every day, doing water aerobics. I used to do 5 miles, and no problem. At first, long ago, but I'd stretch, whatever. I thought it was the hip flexor or solar plexus. And just doing those stretches, pulls, no problem. After I had the COVID, I started feeling like I was 100 years old, and it just radiates that sinew right behind that pocket. If I go like this where that sinew is, and I walk around literally pinching it like a vice grip, I'm wonderful.
Yeah.
But once I release, it just...
So the first thing you need to do is make sure that you're not dealing with a chronic torn tendon or something like that. But if that's okay, then most likely what you're dealing with is a peripheral nerve problem. And common nerves to that area would be like the ilioinguinal and ilioepigastric nerves, which go down into that groin area. They can even come down into the upper inside of the thigh area. And so the thing about peripheral nerve pathology is it's very, very logical. And again, going back to the Rosetta Stone example, once you understand which nerves go where, when a patient comes in and says, I have pain here, you're like, okay, there's 2 or 3 nerve problems that could be causing that pain. Physical exam will usually give you some additional information. And then if you think, okay, this looks like an ilioinguinal or iliohypogastric nerve, you have the patient block those nerves. If that's the source of the pain, it'll shut the pain off just like that. And then you have your diagnosis, and then you can consider some kind of surgical intervention.
Okay.
Yes?
My husband has a nerve pain in his back that only hurts if he's moving or standing. So you talked about, we lay them down, and if we touch where it is, they go, oh yeah, that's it. For him, when he's laying down, and they've done that for him, it's not...
Well, where in his back is the pain? Is this your husband?
Yes. Yeah, it's right below his scapula, about that far away from the spine.
So not all pain is peripheral nerve, but it sort of depends. Like if the pain is very like with a certain movement or a certain thing, that could be axial, meaning there might be arthritis in one of the facet joints. Spine can cause pain when there's a problem with the vertebral body. The disc can be independently painful, can cause pain.
It's not
Phys-
on the spine, it's
Off to
away
the
from
side.
spine.
Okay, so then at every level that comes out, remember the superior clinial nerves, those ones that come out of the bottom? At every level of the spinal column, there's one of those posterior cutaneous nerve branches. And these nerves have to come up through several layers of muscle and fascia and can become pinched at any one of those locations. And so if he can identify where the pain is,
He can.
then you could try a diagnostic block and see if that makes the pain go away. If it does, then there's an operation to go and find that nerve and disconnect it.
Thank you.
Yeah.
Another question.
Yeah.
So I've had a lot of SI joint pain for a while, and I went to a pain management doctor, used injections. The pain would go away.
Did you do an injection into the SI joint?
Yeah.
Okay.
Back. And I went to Explore Park with my family, and in Mexico, Playa del Carmen. And we did the off-road vehicles. And
Rough ride.
I was in the back, and my little sister was driving the vehicle, and we hit every damn bump there was.
I imagine.
And I came home from Mexico. The Saturday after Christmas, I woke up, I was like, I can't move. And I talked to my chiropractor, and I said, can you take an x-ray, because I think it's my tailbone, but I don't know.
Well, does the pain feel like it's right at the your tailbone's basically right at the top of your butt crack.
Yeah.
So if that's where the pain is,
There.
yeah, you could.
And I went in, he talked to me, he's like, I don't think it's your tailbone, I think you aggravated your SI joints. But I was getting a lot of...
You know what, though? Sometimes you have to stand up for yourself. And I will say this about pain management doctors. They have very little idea where pain actually comes from because they don't know the peripheral nerve anatomy. If you go to a pain management doctor and you say, I hurt here, they'll stick a needle there. Or, they'll sort of work up and down the spine. But they really have very little ability to actually diagnose the source of the pain. If your pain is right around the coccyx, the tailbone, SI pain is not referred to the coccyx. You can't really have SI joint pain without at least having pain in the vicinity of the SI joint. So if your pain is all coccygeal in location, then you may have a fractured coccyx. You could have an injury to one of those little nerves, those little sensitive nerves. There's not that much tissue actually between the coccyx and the skin. So if you're banging around in a Jeep traveling through the jungles of Mexico and you hit that place hard several times, that can injure those little nerves. They can become damaged, they can become stuck in surrounding tissue, and that can cause a lot of pain.
I'd be at work and I couldn't sit. I had to buy me a donut for my car.
Yeah.
And I came to Scott, and he knows it. And I went to my pain management doctor. He did injections. He said, I think it's your SI joint. Get it fused. I went to a surgeon. My insurance wouldn't cover it. So I was like, well, if they're not going to cover it, then I'm not going to do it.
I mean, one thing I would recommend is never get your SI joint fused unless you've had a diagnostic block that took away your pain.
The pain came back, so I canceled the surgery. And I haven't had pain, but Scott thinks it was my nerve. He wanted me to come visit you.
It could be, but nerve injuries can recover. One thing about peripheral nerves is they are programmed to regenerate. So as long as the nerve injury isn't too severe or the nerve doesn't end up stuck and compressed, a nerve injury will regenerate and you can have cessation of the pain. Back there.
Okay, so this is for this person here. So 2 years ago, she was struck by lightning. Oh my God. And so
Wow.
she's got numbness from the waist down, and then tingling and numbness and pain, like basically head to toe.
Mm-hmm.
But if she gets bumped or jarred, like she was hit and fell over the 4th of July, it like reactivated all the weakness from basically neck down.
Mm-hmm.
But what would be like the best way to help her regain feeling, or?
Well,
whatever from the waist down.
yeah, I mean, electrical injuries, whether the person gets electrocuted, those are the ones I've seen the most, is when they touch a high voltage line. That can cause nerve compressions to develop. The thing that I would recommend is having a good peripheral nerve evaluation. A peripheral nerve evaluation will let you know if the patient shows signs of nerve compression or not. If they have like nerve pain, but they don't show any signs of the nerves being compressed at locations where the nerve can be compressed, then there's probably not a lot somebody like myself could do for it. But and it doesn't take too many nerves compressed at a few levels to make you feel like your whole body's kind of achy, numb, painful. So you just have to have a good peripheral nerve evaluation and see if there's any evidence of nerve compression. And then a lot of times if people in a situation like this, they haven't really carefully thought about the pain. So if you ask them like, where do you hurt like the most? What's the number one thing? And they start to think about it and evaluate it for a while. Sometimes they can say, well, yeah, it's this part of my thighs that hurt that's the number one problem, or my feet are the number one problem, or whatever the case may be. And so what I do, I some of the patients I see have a very simple problem. It's one nerve, Other patients are very complex, and I always tell them it's like peeling the layers of an onion, You have to figure out where all the landmines are, and then with the help of the patient telling you sort of what their worst problems are, you sort of go for the worst and you peel a layer and see what the effects are, and then you can continue on.
So is it mostly for pain that you would help with, not the numbness?
Well, pain and numbness go hand in hand with peripheral nerve compression. When a nerve is... So one important thing to understand is some doctors will tell patients, oh, it can't be a nerve problem because you don't have numbness. Well, an injured nerve, a compressed nerve, can present as just pain without numbness. It can present as just numbness without pain. But I would say most often it's a mixture of the two. So, like for example, with carpal tunnel syndrome, most patients who have significant carpal tunnel syndrome will have numbness and paresthesias, tingling, all that, but they'll also have some component of aching or burning. When you decompress the nerve, both those symptom types go away. So, yeah, when I do surgery on somebody's got a compressed nerve and they have the skin's numb and they're having pain, if it's an important nerve that you want to decompress, then the goal is to get rid of the pain and restore normal sensation. Sometimes, though, with smaller nerves like the superior cluneal, there's no good way to decompress the nerve and to know that you've decompressed it because the anatomy is so complex. So the better thing there is if the patient just has numbness, I say live with it. And most people with non-painful numbness tolerate that very well. It doesn't really bother them. If you just have some numbness somewhere but no pain, your brain kind of forgets about it. So if people have numbness, I tell them not to worry about it. If they have numbness and pain and these little nerves are injured, usually what you're looking at is a trade-off for maybe a little more numbness to get rid of the pain. But again, once that pain's gone, the patient will get used to the numbness and they won't think about it. Yes?
A question about if you've seen or if you see anything related to fungus, with toenail fungus with neuropathy.
Yes, so that's an interesting question. So, most of the time when you see those thick, brittle, crusty nails and you think, oh, somebody's got a fungal infection, nerves control just about everything. Nerves are hormones. So nerves control nail growth. They control sebaceous glands, sweat glands, how hair follicles grow. So it's very common in people with peripheral neuropathy that all their hair may fall out in the lower legs. They can develop those thick, crusty toenails. They may develop very dry skin, or their feet may sweat profusely all the time. These are all kind of these sympathetic manifestations of peripheral neuropathy.
So you're saying that peripheral.
So in that situation, you would take fungal medication and it wouldn't really do anything because it's not a fungal infection. It's a feature of bad nerve signal to the nail.
And that's why the fungus comes in? It's not growing?
Well, if you treated it appropriately for fungus and it didn't, a lot of times when you see patients with peripheral neuropathy, they'll say, yeah, this toenail went all, wonky like this. I've been treated multiple times for fungal infection and nothing ever gets better. So yeah, you could get a fungus that comes in there secondarily, but the nerve problem itself can cause the nails to grow funky like that. Oftentimes, once it's like that, the best solution is just to remove the nail or shave it down. You know. Yes.
I had a baby 6 months ago, and ever since I have excruciating pain as if I've walked 10 miles. My legs and my feet ache like I've walked 10 miles.
Is the pain mostly below the knee level?
No, it's my whole entire leg. I did have sciatic.
One leg or both legs?
Both legs.
Okay.
I did have sciatic nerve pain when I
During
was,
pregnancy?
yeah, and
Okay.
I still feel it. What do you think is causing this pain?
So you could easily have bilateral piriformis syndrome. So the gravid uterus, when the baby's growing and it gets bigger and bigger, that uterus sits right down in the pelvis. And I don't remember who was, maybe you that asked the question about the holes in the other side of the sacrum.
Like in the front.
Yeah, in the front. So out of that anterior surface of the sacrum come the big nerves that make up the sciatic nerve eventually. And so you have that plexus of nerves, and the gravid uterus can be pushing right on those nerves. So one of the common things that pregnant women experience is sciatica during pregnancy. Very often it resolves once the woman gives birth, but not always. And so, you may have developed some piriformis syndrome, and even though you've given birth to the baby, you may still be dealing with some compression of those nerves. A good physical exam with imaging and nerve, diagnostic piriformis injections should be able to figure out what the problem is. If you've had a lumbar spine MRI and it's normal, which I would assume is probably the case given your age, then it's not just, it's like this mystery pain, we can't figure it out. There's ways to figure it out.
Do you think having them have me push until the baby was right there and then wait 45 minutes with the baby right there until the doctor came was what caused it?
It could have contributed. You were already having sciatica pain in the latter part of your pregnancy, right? So things were already pushing on those nerves. The other thing is the position that a woman's in to give birth. You're kind of in that, dorsal lithotomy. You're somewhat sitting up, but also sitting back a little bit. That puts a lot of pressure right on the piriformis muscle sciatic nerve interface. And all it takes is 30 or 40 minutes of uninterrupted pressure on a nerve, and you can develop a nerve compression. Has anybody ever heard the term Saturday night palsy? So this is a common thing that happens when somebody's been out drinking and they pass out and they lay on their arm and compress the radial nerve. They don't move for an hour or two because they're, stone drunk. They wake up and their wrist is like this. Most of the time for those types of things, the wrist will come back in a few weeks or a couple months. The nerve will recover, but it's been compressed, and because the person was so drunk, they don't roll out of the way like you normally do when you're asleep. Yes?
Consults here in Utah or just
I would if Scott asked me to, but normally no. Yeah, I have patients that come from all over the world because there's so few surgeons that do this, and so it's just more efficient for me if they fly to me in Las Vegas. Hang on, I think she's next.
Just a continuation
Yeah.
of his thing. He did have the cortisone shot, didn't work. And then he had the two things where they were blocking the nerve, didn't work. So what would be
Well,
the best?
so when you go to a pain management doctor and they do nerve blocks, almost always they're injecting the spinal nerve root. I would be blown away if they were actually going for one of these posterior cutaneous nerve branches.
Okay. So is the best thing to talk to you or talk
Well,
to
first of
another
all,
guy?
since this problem is right in this area, right?
It's more to the right. Yeah. To the right.
Okay, but it's within, you divide the spinal column up into the cervical spine, then there's the thoracic spine, that's the part that has the nerves connected, and then your lumbar spine. So this sounds, based on where you're describing it's the thoracic spine.
Right.
You should start with an MRI of the thoracic spine if you've not had one. If it's been more than a year, I'd recommend getting a new MRI of your thoracic spine. You always want to make sure that there's not a spinal problem first. The last thing you want to do is go gallivanting off and thinking it's a peripheral nerve problem when there's a clear spine issue. Because to address these problems, you want to start at the top of the chain and work your way down. So that's what I'd recommend there.
You said several MRIs of the chest.
Yeah, no, you'd want an MRI of the thoracic spine.
Okay. Thank you.
The other problem with these peripheral nerve issues is that most of them don't show up on any kind of imaging. So if you don't know the anatomy, everything looks normal all the time.
Thank you.
Yes. I'll get to you next. Mm-hmm. I know Eric. Yeah, sure. Mm-hmm.
Since you have to find how to diagnose all this, it's difficult, and most people don't have that ability. How do you find it?
How do I make the diagnoses?
Yes, can you find it through your hands and feeling the fascia and the bone?
So this is how I approach these problems. First of all, because most people are not in Las Vegas, I have a system where I send out a little information pack to them, and the centerpiece of that is I have them write up what's called I just refer to it as a patient summary. If somebody can give me a good description of how the pain started, where the pain is located, and if it travels or radiates somewhere, describe that pathway accurately, probably 80% of the time I can tell you what the problem is just from reading that description. So that's where the anatomy comes in, right? If your peripheral nervous system is a black box to me, you could talk all day long about where your pain is and where it travels. And you know what that sounds like to a doctor? Do we have any Charlie Brown fans? You know Charlie Brown's mom? Wah, 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 wah. That's what it sounds like. It's a foreign language to doctors who don't understand peripheral nerve anatomy. The anatomy is, I can't stress it enough. And so once you know the anatomy, the patient describes the problem, then you get a very good idea, and then you can do a physical examination.
And do you do that?
Yes. So
The physical hands-on.
yes, it's all hands up. History and physical exam is by far the most accurate and sensitive ways to make these diagnoses. Imaging and diagnostic blocks are nice additions to that, but the key components to a peripheral nerve evaluation are, number one, a careful motor exam, because certain nerves go to certain muscles. So if I test you and a certain muscle is weak, right away I know there's something wrong with this nerve. If somebody has foot drop and weakness with knee flexion, then I know it can't just be the common peroneal nerve here, because compression of the common peroneal nerve on the outside of the knee cannot account for weakness in the hamstring muscles. Once I see weakness in the hamstring muscles, I know that we're dealing with either piriformis syndrome or possibly something at the spine level. So the first thing I'm going to do is get a lumbar spine MRI and make sure we're not dealing with a herniated disc that's pushing on the L5 nerve root. If the lumbar spine MRI is clean, then the only other really good explanation for that knee flexion weakness, the weakness in the hamstring muscles, is a piriformis syndrome.
Which is amazing to me, because I know someone who does what you sound like you are able to do. Not many people can do that. And
Do you know their name? Because I'd know if they do it or not. I know everybody who does this. There's like 4 of us.
This is a new. Well, let me just tell you what he did. I said, "Why is this shoulder indented?"
Mm-hmm.
And he has hands that can feel. And he said, "It's not your shoulder. You have something going on in your back right there." And when he was touching, it was a place that was numb. And I didn't even think about that, because the pain is where, or what you can see, and this makes it.
Patients almost always want to focus on the pain. That gets everybody's attention.
I was amazed when he went there, and when that's not even what, it's just not getting what it needs, so you atrophy over there.
Well, yeah, I mean, so the nerve that innervates this muscle is the axillary nerve. That's one of those branches that comes off the brachial plexus. So the axillary nerve can be entrapped right here there's muscles that form like a little space like this called the quadrangular space, and the axillary nerve can be compressed here. That happens a lot in overhead throwing athletes, but the same problem, you could get atrophy if the problem was up higher, like a brachial plexus compression or a nerve root compression. So you got to rule out all these locations.
Can you feel it when you're doing that exam? When you start feeling the body, do you feel it in your hand?
The only place you can really feel a peripheral nerve is right here. You can actually feel it, especially if it's swollen in somebody who's got peripheral neuropathy. The other part of the exam, what you're doing is you're looking for tenderness and or what's called a Tinel sign. So I know where the nerve can potentially be compressed. So like, for example, the ulnar nerve, your funny bone nerve, can be compressed here. That's called cubital tunnel. You actually can sometimes feel this nerve too, especially if it's subluxing or popping over the inside of the bone there. But generally you don't feel the nerve. But what you do is you put pressure there. There's two common physical exam findings. One is tenderness when you push on the spot, and the other is when you percuss like this. They'll have what's called a Tinel sign, and that's a little tingle that travels down the nerve. And that's an indication that the insulation on the nerve fiber is broken down, and you're actually stimulating the axon fiber. It's like you're touching the copper wire, and that'll cause a tingle to go down. I think we need to wrap this up. Scott's got some patients that are coming in now, so thank you all for coming out.
Yeah. So again, if you want to get in touch with Tim, Dr. Tolstrup, sorry.
It's okay. You can call me Tim.
We can give you the information for him. The forms that you got, if you wanted to get in touch with Boston Scientific about their options, you have the form there.
Of those two nerves.
Anterior femoral cutaneous nerve,
lateral
femoral cutaneous nerve,
but we're here to help.
and posterior femoral cutaneous nerve.
Thanks for coming.
Posterior.
And then you just think of like lateral is the outside here,
Right.
anterior is kind of the inside front, and posterior is the back.
Yeah, it's like a man's groin.
Yeah.
In the beginning.
You know, women actually can injure those nerves very easily. Things like a C-section through a low phalansteal incision. Very frequently, those nerves are injured. Those groin nerves.
I've had both my kids in
A
less
tummy
than-
tuck, you know, abdominoplasty. All these. You can't do surgery without risking injuring a peripheral nerve. Now, thank goodness, most people, don't develop a peripheral nerve injury after surgery, but it can happen.
Yeah. I've had both my kids in less than 4 hours, a couple of pushes, no sleep.
Nice.
But it's because of swimming and doing
Yeah.
that kind of exercise.
There's another actual thing that can happen, like down in this area, that's not primarily nerve, and that's what's called they call it a sports hernia. And this can be sort of micro tearing of the insertion of the rectus